Thank you very much, Carolina, for the nice introduction. And thank you for letting me talk about this topic, to consider food surgery in perspective of the future. And we all know that in the course of Duchenne, there will be an aqueous foot, the possibility of an aqueous foot develops. Already the young child walks on his toes, and you can see over here then the aqueous position of the foot. The walking on the toes is due to the weakness in the calf muscles and the pelvic muscles, but also the fibrotic changes in the calf muscles make the feet become contracted in the equinus position. You can do something about it. You can do a treatment like physiotherapy, stretching exercise. You can wear braces. And in this balloon, you can also see the name of wheelchair. And this is what you can see. I picked this picture from a very young child with Duchenne muscular dystrophy in his wheelchair. And looking at this child, you can actually see that his feet are in an equinus position. If you think of how much per day you walk and how much per day you are sitting, the majority of the people are sitting more hours than walking more hours. So this is a position where the contractures can be stimulated to develop. To retard this, you should adjust your wheelchair already in a good foot position. I talked about this last year. You can also make use of bracing, an ankle foot orthosis during the night. And if a boy doesn't want it during the night, you can actually wear it during the day in non-ambulatory persons. But the idea behind this picture is that you should start young. You should start young in preventing an equinus position of the foot, and also start young with wearing braces, because it's much easier to become adapted to an ankle foot orthosis when you are young than when you're a teenage boy. If you do not too little, then you can see this in adulthood. And in adulthood, you can see these type of foots. I have seen them when I was a young rehabilitation physician, and you can see that there are protruding bone elements, that the toes are contracted, and they can have also pressure points on the toes. And if you look more closely, you can also see that the foot you can try to get shoes on the feet, but it is still a strange position of the foot on the wheelchair rests. And if you do nothing, you can get this. This is not the fault of a neuromuscular specialist. This young adult was diagnosed with Duchenne only when he was a young adult. So he developed a severe contractures. You can see that he is sitting in a position where he is balancing his body, but the feet are turned up, and they are at risk for getting pressure points over here, but also his knee is also at risk for developing pressure points. So preventing is better than letting it go. So what are the risks for an adult with an equinovarus deformity? Well, first of all, there is pain, and pain in the foot because it's unstable. It's hurting. The skin is hurting. The bones are hurting, but it can also, on those points, you can also have ulcers on the protruding points, mostly bone, but also the lateral edge of the foot or the dorsum of the foot. And I could have shown you severe pictures of ulcers, but I think the message is good enough to see those awful pictures. You can also have fractures, as the foot is, as the whole skeleton, osteoporotic. And if a boy or a young man rides in his wheelchair and bumps into anything, and the foot is not protected, it can be fractured. But also these feet that are so contract, and trying to have them hygienic care is by handling, it can also cause fractures. These foot are always extra cold, as you can only put socks on it, but not warm shoes that protect the foot against all weather conditions. There is diminished blood circulation. Normally, you can, the boy with Duchenne or the young man with Duchenne can wobble with his toes and thus stimulate the blood circulation. But if you can't move your toes anymore due to contractions, there's also a retarded healing of wounds. But as many people, and in line with the talks on sexuality, you want to have friends or a girlfriend or a boyfriend, and having those feet on those in the wheelchair only with socks on or with very strange shoes on, it is not a very good appearance to get acquainted with somebody else. So you could consider foot surgery. When I was a young rehabilitation physician, the Rideau procedure was done in several countries, and the Rideau procedure aimed at tenotomy at several levels in the leg. The idea behind the Rideau procedure was that the boys with Duchenne would walk longer if they had a good line out of their legs. In studies, it was proven wrong, so it was negative. And probably from that point on, the idea of foot surgery was a little bit less in the picture. Some groups still performed foot surgery, like my group, myself, in several locations. We asked the surgeon to intervene on these foot deformities, but also in the USA from Dr. Schur. And he showed that in 24 patients who underwent foot surgery in both feet, after 8.5 years of surgery, the clinical picture was quite satisfactory. Another group in Canada asked 88 teenage boys by questionnaire what would they do, and they divided the group in non-surgery and with surgery, foot surgery. And they showed by questionnaire that there was no difference in the groups between the shoe wear, hypersensitivity, cosmesis, but be aware of the fact that these boys were teenage boys. So they weren't yet adults. So the full deformity was not yet developed. But what they mentioned was that the equinus contracture was significantly worse in the group that was not operated on. So surgery helps. But what kind of surgery should you consider then? You could either do soft tissue surgeries like tendon lengthening, tendon release, or gastric slide, where you cut the gastric muscles on several levels depending on how much lengthening you want. Or you could consider bone surgery, taking out the talus, the talectomy, which makes the foot in a direct, good position to the ankle. And you can combine it with fixation in the midfoot. But all surgery should be followed by splinting. So what would you choose? Well, my colleague Saskia Houwe performed a study. It is a small group, and she compared the soft tissue intervention with the bone intervention in 18 boys. There were 13 boys with soft tissue intervention and 5 with bone intervention. And if you look at the age of the two groups, you can actually see that the soft tissue interventions were much earlier in age than the bone interventions. Then you can also see that the equinus position was much worse in the group of the bone intervention than compared to the soft tissue intervention. In these groups, nearly all used corticosteroids. They used their splints, but it didn't work enough. And this was the reason why we indicated there for surgery. Most of the patients were indicated for good foot placement on the footrest. Good positioning in the wheelchair is good for the feet and good for the balance and good for the stability of the whole body, for the spine, for the balance of the head and the arm function. But also some had pain and some had problems in wearing shoes, and some had problems with wearing orthosis, and 2 boys were not able to make a standing transfer, or being in a standing table. So that was no indication. And happily enough, only a few had pressure spots because we want to prevent this. with this surgery in both the osseous group and the soft tissue intervention group, the position of the hind foot was better, much better after the surgery. But if you look at the complications post-surgery, then the group of the soft tissue, which is the black line, and compared with the group of the bone surgery, which is the gray line, looking at pain, not having pain anymore, well, you can see that in the group of the soft tissue, the pain decreases quite quickly, while in the bones group, it was still present after 2 or 3 years. And if you look at edema, again, in the soft tissue group, the edema decreased quite quickly, while in the bone group, the edema was there for at least for 2 years. So to wrap up this all, the conclusion can be that prevention of foot deformities is the best managed. So a good position in the wheelchair and use of orthosis next to stretching exercises. But sometimes it doesn't work. And so if this is not sufficient enough, consider foot surgery to prevent complications in adulthood. So the point is that consider it in an early age, while the problems are not yet there, but the risk is there that in adulthood, you can develop an ulcus or a fracture or pain. And looking at the results from literature, it is preferable to do foot surgery in an early non-ambulatory phase, and preferably soft tissue surgery due to the complications. But the main topic I want to emphasize is that convince the child with DMD and the parents to invest early to prevent problems in adulthood. So act early, and talk to them about the risk they have in adulthood if they do nothing. And with this, I want to end my presentation. Thank you for all.